Neihulizumab represents an anti-PSGL-1 antibody, which is currently under investigation for a number of refractory autoimmune conditions. We performed a study in steroid-refractory and treatment-refractory acute GVH. In parallel, there are studies that are being performed amongst patients who have treatment-refractory ulcerative colitis as well. And so these are both areas that are kind of similar in terms of pathology, which is why the investigation is in place. So the way that this study was performed was we performed it in two phases. The first phase, we performed administration to evaluate pharmacokinetics, to evaluate an initial signal. And so we enrolled patients with steroid refractory or treatment refractory acute GVH that had skin manifestation of disease. And so what we wanted to see first was whether there could be any improvement in rash, which is a very objective way of determining initial response. And so for the first part of this study, we enrolled patients who had skin and other site to mostly evaluate whether we saw any improvement, before moving on to a multi-dose study. And so in this first phase, what we saw was in over 50% of patients who were administered this agent, we saw improvement, not necessarily complete improvement, but partial improvement of rash after one dose of this agent. That allowed us to move to a multi-dose schema where patients receive this agent at weekly doses for 4 weeks. So in that portion, we enrolled patients who were steroid refractory, so patients who received steroids and then had steroid refractory acute GVHD. We enrolled patients who were treatment refractory, defined as patients who had received steroids and an additional treatment for their acute GVHD with still persistence of acute graft-versus-host disease. So most of those patients received steroids and then subsequently received Ruxolitinib, which is now approved for steroid-refractory graft-versus-host disease. So in terms of efficacy, this study also demonstrated some very interesting signals. So in their first phase, we saw that there was some resolution in terms of skin manifestations. What I thought was the most interesting result of this study was for these treatment-refractory patients. So these are patients who did not achieve an adequate response with Ruxolitinib. We saw responses in a fair proportion of patients. So in over 50% of patients, we saw some improvement or control in their graft-versus-host disease. Many of these patients continued on with Ruxolitinib. So in this study, we didn't mandate that patients had to stop. And so that's in line with what's typically done in the real world. So with treatment refractory, when we reach that state, many patients, in our practice, that are off this trial, what we do is we typically add treatment to Ruxolitinib. And so off trial, for instance, ECP is a common treatment that we add on to Ruxolitinib if we're not seeing an adequate response. So in these patients who mostly continued on Ruxolitinib and Neihulizumab was added, again, over 50% of these patients had improvement in their graft-versus-host disease. And not only that, we saw essentially durability and survival in this population as well. We had previously performed a study where we looked at real-world outcomes for patients with treatment-refractory acute GVH. What we saw was about a third of patients when we added ECP or our next intervention had improvement, and their survival was very limited in the range of about 2 months. And so in this study, what we saw was amongst patients who Neihulizumab was added, perhaps due to safety as well as efficacy, over 50% of these patients were alive at 6 months as well. So certainly where I see this agent potentially fitting in the future is, one, we know certain patients are more likely to be steroid and treatment refractory. Patients with multi-organ steroid refractory acute GVH involving the GI tract and perhaps another site, liver acute GVH that's steroid refractory, these tend to respond a little less than half the time to Ruxolitinib. So I think in the future, potentially these patients could be considered with this combination up front, or this agent potentially plays well with Ruxolitinib and could be an add-on when treatment refractory is determined in patients. And so that's the takeaway, at least from the results so far from that study.